Good morning, Maryland. I'm Christian Schaefer, joining you on the WMAR2 News Facebook page, and I have two very special guests with me, and we would love to hear some of your questions too, because we're talking about pain management this morning with two of our experts from GBMC. Dr. Justin Slavin is a neurosurgeon at GBMC. Good morning to you.
Good morning.
Thanks so much for coming in. And also I have Dr. Emg Study.
Good morning.
So was I close?
You were very good.
I was very good on that. Okay, thanks so much both of you for coming in. As a neurosurgeon,
yes.
When we talk about pain management, how do you see your role in that process?
So I am a neurosurgeon. I specialize in disorders of the spine. Oftentimes the presenting symptom for spinal disorders is back, neck, leg, arm pain. So people with pain complaints sometimes do get referred to neurosurgeons for surgical treatment of these conditions.
And sometimes they may need surgery. Sometimes they may have other options to go through. And do you work with patients who've had surgery and those who may have other options?
That's correct. I'm a physiatrist. I practice pain management. My role in pain management is to assess the cause of why people are in pain and come up with a treatment plan, which may involve sending to surgery versus doing interventional procedures, physical therapy, things like that. So our goal is to try and evaluate and diagnose what's causing the pain and then come up with a treatment plan.
It sounds like step one would be for someone to come forward and say, look, this is bothering me. They might go to their primary care physician. Can they come into CureSmart also and just ask questions for you guys as well?
Absolutely. Come in and get an evaluation, and we come up with a diagnosis and a treatment plan to match what's causing the pain.
So, Dr. Slavin, some people, when they talk about pain management, the mind may directly go to, okay, are we talking about opioids? And there's this, everyone's been aware of what's been going on with the opioid crisis, both here in Maryland and nationally. What are some of the things that you think about when we talk about pain management as it relates to the work that you do at GBMC?
Absolutely, yeah. So I see lots of patients who come in with sometimes very difficult to treat pain. Outside of certain urgent or emergent conditions, I will oftentimes refer people to pain management to see if we can control the pain through non-surgical options. Some of these options can be both therapeutic, meaning that they reduce the amount of pain, but also, important for me, sometimes they can be diagnostic. Sometimes we're having a difficult time figuring out what the source of the pain is and what surgical procedure might be most effective. Diagnostic procedures like pain injections can both help the pain, but also give me an idea what's causing the pain.
And what might eventually make it better.
Exactly.
So, Dr. Study, what kinds of chronic pain do you see? When people come in, is it always back pain, or there's lots of other issues that people may have?
Seems like it's everything under the sun. So
Really?
back pain is probably one of the most common things that we see. Anything in the spine, whether it's neck or back, actually, is what we see. Sometimes we see patients with chronic headaches. Sometimes we see patients that have total body pain from something like fibromyalgia, joint pain, shoulder pain, knee pain, leg pain. So pretty much anywhere in the body we evaluate.
And what kinds of treatments can people get? And this is not necessarily talking about surgery, but I'm not sure if people understand that at times physical therapy alone, is that enough sometimes to fix what's going on?
Right. So if someone comes in with an acute back pain problem, first our goal is to try and assess why they're having that pain. Our first line of treatment is often physical therapy because acute soft tissue injury, which is usually the majority of why people get hurt initially, is something that responds really well to the treatment. The role of physical therapy is to try and identify what triggered the pain and learn activity modification, develop a home exercise program so that they can prevent the pain from coming back again. So yes, to answer your question, a lot of pain can go away with physical therapy.
And I just wonder if people just aren't aware that if they would, pick up the phone or stop in, this problem that they've been having, there's ideas that can help with it.
There's ideas that can help with it, and there's also this fear of if I move, it hurts, so physical therapy is going to hurt me if I go. And lack of movement can also make things worse because you get stiff, you get tight, it's harder to move, you get deconditioned and weak. And so when someone goes to physical therapy, they're now moving muscles that may have not been moved in a while, depending on how long that injury has been there. And so there's a lot of fears, and it can be more sore. Sometimes we have to do an intervention to try and decrease the acute flare-up of pain that they're having so that they can go back to physical therapy and get a better response from it.
I think, Dr. Slavin, that some people who have back pain, they may be concerned that they could do some physical therapy and it's not going to get better. And there are some people who do need surgery. And if they have it, they're concerned that it's A, not going to help, and B, they're going to be dealing with this long recovery. They're not, I'm wondering if people are confident that they will get better when they have a serious back problem that requires surgery. Have there been some advances that you can talk about with that?
Well, let's first talk about what surgery can offer people. Back surgery, it's a complicated issue. There are certain conditions that respond very well to surgery. People do wonderfully. There are certain conditions that may not respond as well to back surgery. Back pain, again, there's maybe 30, 40, 50 different potential causes for a back pain problem. The thing that I always tell patients is that if we see nerve compression such that you're having pain that's very strongly reproducible to a very specific area, I feel very confident by relieving pressure on a nerve, we're going to make certain types of pain better with the surgery. Back pain, we may or may not be all that successful, and that's why surgery needs to be very carefully considered for these patients. You may, at the end of surgery, still have some back pain, even though we've gotten rid of a lot of the leg part of the complaints. Now, as far as what we can do for patients to try to minimize the recovery, the pain that's associated with back surgery, I'm a big proponent of trying to be an advocate for minimally invasive surgery. And what that means is basically trying to minimize the trauma to one's body associated with performing these spinal procedures, whether it's decompressing a nerve, stabilizing the spine, correcting malalignments. These can all be done through less invasive means and hopefully provide the patient with a smoother and easier recovery with less pain.
Well, it's interesting even that you're thinking about the recovery even before the surgery, right?
Yes.
So part of
Right.
that is the strategy of how the recovery is going to go, depending on how we do this surgery. Maybe it's an easier recovery if we do it a certain way. Those are all considerations that go into it beforehand.
Absolutely.
Really. So should opioid pain medications, though, do they come into play in every case? In some cases, should they, given the state that we're in right now, should they be kind of eliminated? What's the role that they still play in 2018?
Well, certainly for post-operative patients, I mean, they oftentimes do play a role. We always try to minimize. We try to do as much as possible to minimize the reliance on opiate pain medications. But essentially, opiates are used for the control of acute short-term pain. Surgical pain, post-operative pain, that's a prime example of something that does respond really well to opiates and does not require long-term use of opiates.
So,
Can I add to that point?
Yeah,
I'm
I was
sorry.
going to ask you
So-
too, because it's part of. It can be part of the recovery process, correct?
Right. So, as he said, for post-operative pain, that's something that we commonly use. Now, I think the first thing is evaluating why someone's having pain. Not all pain requires opioid medication, and for chronic pain, opioid medication is not the first line of treatment. Opioid medication should be used as part of a multidisciplinary approach to treating pain. So, using more than one modality to help with whatever their pain generator is, whatever their cause is. So from a long-term perspective, our goal is always to reduce and try and wean off, pain medication. But from a short-term perspective, sometimes it's necessary so that they can tolerate doing the physical therapy or the other interventions that can make them better.
One of the things that's happened with the opioid crisis that people are at least aware of it. I think people now, if they were to have a procedure like this or a problem like this, they might talk to the doctor beforehand about how many of these pills am I going to have to take. They might have some concerns about themselves or a loved one who is having a problem.
Yeah, sometimes we do see patients before they have a scheduled surgery, or we might be the ones that refer patients to surgeons to treat whatever their pain condition is. And we often have discussions regarding what the expectations are with using opioid medications, making sure that they're taking them as prescribed, not increasing their doses on their own, which can lead to some dangerous consequences.
Well, I'm just concerned that in the past, maybe even not that many years ago, that it wasn't even that much of a consideration potentially. And at least at this point, people are aware that there are other things that you can do to mitigate pain, and that if you do use opioid medications, they need to be pretty careful about it.
That's
If they're
correct.
very serious medication.
They're correct.
Yeah, but they do have a role in many treatments and recoveries.
Yeah, I think
correct.
these concerns are a very healthy attitude from our patients, and patients do come in much more educated about the concerns of opiate use. And I just provide reassurance as much as I can. If you take the medications in partnership with our guidance as directed, we try to minimize all of those risks. But it still plays a role.
It sure does. I have a question from Terry on Facebook, and it looks like she's having some medical issues that we can talk about because she's writing in. I don't fully understand what her problem is. You guys might do better than I. Are they aware of pain caused by an antibiotic called fluoroquinolone? I'm sure I didn't say that wrong. Right, Cipro and other eye drops and ear drops. She's saying doctors are, LASIK surgery causing eye pain and antibiotics, nerve damage from stuff like that, from different kinds of antibiotics and other procedures that people have had on different parts of their body. Are there treatments or help that you can get for issues that don't necessarily arise from muscles and bones, potentially other problems that you guys have ever seen?
Yes, there are multiple causes of why someone's having pain. It sounds like that question is more specifically regarding an antibiotic
Like
that
a
might
drug
have
that would cause it.
A side effect to an
a side
antibiotic.
effect.
Is that something
Yeah.
that happens or that you can get?
Quinolones can cause tendon ruptures in rare cases to the feet. As far as pain, I haven't had any patients with that experience.
Yeah.
But speaking more generally, certainly there are side effects from certain medications that can cause neuropathy, painful paresthesias or abnormal sensations. Chemotherapy is a common one where you can
Really?
see nerve
Yep.
damage as a result. So there are
Radiation.
medical
Yep.
causes for pain that sometimes we have to seek interventions or medical therapy.
And I just keep going back to that when people have these issues that they can talk to their doctor about it. I feel like there's a lot of people who just don't do that. They feel like uncomfortable coming forward and talking about whether it's their pain issue or an issue with opioids or a family member who's had a problem with that. Some people feel they shouldn't be talking about that. We're almost to 2019. I feel like we should have moved past that.
Yeah,
we
this-
can talk about these things.
There's no reason to be embarrassed about a pain issue or a risk factor that may be involved with it if someone has some concerns for addiction or things like that. Those are things that they definitely need to bring up with their provider. It's better that they talk to us than to talk to a family member that might not know how to address it.
So how do you differentiate between, we talked a little bit about this, between a chronic pain, which you said an opioid pain medication may not be the best idea for that, and just something that's a specific issue that can be fixed more quickly? How do you differentiate between those issues in a patient?
So the timing of how long someone's had a problem, an injury per se, if something's acute, meaning recently happening, that's something that, addressing it quickly may be best, whether that means, if they have a herniated disc and they need to have a intervention, a procedure to decrease the pain, or physical therapy, then so it's more so about the timing of that versus something that's been there for years and years and years, and they've been on pain medicine for years and years and years, but pain medicine might not be as effective after some time because of tolerance or other issues. We usually decrease the medication and wean them off. I'm not sure if I answered your question. Though,
Yeah,
but
well, it just seems like it goes back to the fact that if somebody has a problem, you give them a pill and it gets better. That's not always. Not only does it sometimes not work, it may not be the best course of action.
it's
in many
not treating
cases.
the problem.
You're not treating the problem,
Yeah.
right? And that's how do you do more of that more directly?
That comes with coming in for a physical exam and addressing what's causing their pain. So back pain can be from, like you said, 30, 50 different causes. Our role is to try and determine what's causing it and make an intervention, make a decision as far as what to, how to treat that.
And making sure that there's nothing serious that's underlying it. Just because I generally am a little bit hesitant to recommend surgery for a chronic pain patient. Usually that means that there's something else going on that has not been addressed. If that patient has chronic pain and they've just never been evaluated or worked up for it, certainly there may be a lot of things we can do to help that patient, either surgically or otherwise.
Have you seen patients that have come in like that have had these problems for weeks, months, years,
Yeah.
years without
Yeah.
without having
There are
addressed it?
a lot of
never
people that
came in.
don't go to the doctor. Yeah.
Yeah.
They just don't come in and they've been dealing with it at home for years.
And it turns out that it's somewhat tragic that it could have been fixed earlier, but the point is that it still can be fixed.
I've had plenty of patients say, I wish I came in years ago.
Right. That's incredible. And so what are some of the ways that you evaluate that as far as finding out whether surgery might be an option or even maybe one of those minimally invasive surgeries? How do you make that diagnosis and decide what's best?
Yeah. Well, I mean, I think it starts a lot of the times with some kind of imaging procedure based on clinical suspicion, based on someone's examination. If you go to your primary care doctor, they get concerned. Usually the first step is get a picture. Find out what's going on, see if there's something really obvious. If there's nothing really obvious, we have to go back to the drawing board and do some other things.
Look for weather pain. So one thing that we do, if they have an MRI study that's done and it looks essentially normal or benign, we can do an EMG study, right? If someone has back pain with leg pain, the back pain might be because of their muscles, but the leg pain might be from a peripheral neuropathy, right? So that's a study that's done that is an extension of the physical exam, where we would do nerve conduction tests to check and see how well the nerves are working, and we would do a needle EMG portion, which looks at if there's something coming from the spine or coming from someplace else that could be causing their pain.
Yeah. And again, it shows what nerve is the problem and where the problem is.
Do you ever see patients who are younger people, maybe even maybe high school sports injuries, serious issues like that the parents come in and have concerns about this? Would that get to your level as well, or are there more sports-related doctors that wind up with those types of patients? Or would you see a back injury like that from a younger person?
I mean, younger people, they tend not to have some of these other issues that chronic pain patients have, whether it's severe degenerative disease that is associated with getting older, tumors, other issues. It tends to be more trauma-related. So certainly I see patients who come in with trauma. Someone has a fracture in their spine because of skiing injury or something like that. But it tends to be more of those issues.
Because that seems like potential for someone who had not really been in much contact with the healthcare system, had not been prescribed any kind of medication before, but all of a sudden, now you're dealing with a rather serious injury, which may involve surgery and may involve pain management. How do you kind of get that person involved in making sure that they know that there is going to be a light at the end of the tunnel in a situation like that?
A lot of patient education, a lot of reassurance. So younger people that have sports injuries, definitely there has to be a role of a rehab component, physical therapy, to try and get them either back into their sport or get them back to some degree of quality of life. And opioid medications in younger people, there are higher risk factors involved for addiction to the medicine. So we definitely, if we have to go down that route, keep it for short term and wean them off as quickly as possible. We do procedures, just as with older people, into younger people, whether it's into their back, hip, knee, depending on what their pain is.
Some kids, maybe even some adults, maybe even in this room, can be afraid of needles sometimes if they have to get a shot for whatever it is that there's going to be done. How do you help with that?
A lot of patient education, reassurance. There are some patients that are so afraid of having an injection that there are times that we actually have to sedate patients and allow them to have some medicine so that they relax. And
these are the adults, right?
Yes. But a lot of more so than not, when people have a procedure, afterwards they realize, wow, that wasn't as bad as I thought it was going to be.
Right.
Yeah. So it's just reassurance. I think that's the biggest thing.
So. How do you evaluate, going forward, how it's working? Like, how do we know that we're doing the right thing and that we're using the right strategies? How do you see success in this?
So, as far as what we see, we see patients routinely on a monthly basis, sometimes more frequently, sometimes less frequently. So we're constantly evaluating to see, what their pain is like, what their quality of life is like. Some patients may have had to take some time off from working or not able to do the things that they do on a regular basis. So getting back into some degree of their activity pattern prior to their injury is a big indicator for patients that may have been prescribed medications. Decreasing the need of having to take medications is another big indicator. Interviewing patients and just seeing how they are with their families. Oftentimes they, give us feedback saying, hey, this person's doing so much better, thank you so much. So there's a lot of constant assessment.
That's a good feeling when you see that.
Yeah.
The top of my reevaluation patient form when I come and see patients back in clinic, there's three options: same, better, or worse. That tells a lot of the story usually.
Sometimes if you enter into a program of physical therapy, have you seen cases where it just doesn't seem to be coming together the way you wanted to see, or that may have happened in a different patient. You haven't seen the progress that you'd like to see.
Yeah.
What do you do? What do you do then?
We have to reassess the patient and see if there's something else that we missed, right? If their condition's gotten worse. And sometimes we have to make decisions with regards to doing more aggressive treatments like surgery or interventional procedures.
Are people always coming in hoping to avoid surgery? Or do they sometimes come in knowing, I'm going to have to get something done here? What's the mindset you see most often?
Trying to avoid surgery.
Really?
The vast majority.
Yeah. Vast majority.
No one wants back surgery if you
Right.
can get away with
Yeah.
it.
Correct.
And I wonder, maybe they're just not aware that it's not quite as invasive as it used to be, potentially.
Well, I mean, I think there should be a healthy skepticism towards whether or not someone needs surgery. I'm usually very frank with people. If I think you need surgery for an urgent or emergent reason, I will say, you have one option, and that is surgery.
Mm-hmm.
That is rare. For most people, if there is a way around surgery, I say we should take every option to avoid surgery.
For most people.
You tell me when you can't take it anymore. If I think there's an indication for surgery and you're at the end of your rope, nothing's working, that's the right time.
You think that might be when it starts to really affect more daily activities?
Everybody's
Yes.
different. Some
Everyone's-
people are willing to tolerate
Take
a lot
pain.
more discomfort and disability than others. Some people, their quality of life is so important to them that if they can't be very active, they're willing to take a gamble and the risks of surgery.
And let's talk again with both of you briefly about when a patient is prescribed an opioid pain medication. You or your team monitors that patient as
Yes.
far as, that they have this certain number of, because you can't stay with them 24/7.
Right.
But you have to, at this point, I think people should be aware that a patient who is prescribed those medications, they're going to be monitored rather closely. Is that how it's been going?
Yes, that is correct.
How does that process work?
So, they have to come in for an office visit. We certainly don't like to get into the habit of sending medications without seeing them. We have to do drug screens, whether it's by saliva versus urine screens. Sometimes we have to call patients in for pill counts to make sure that they have the number of medications that we're prescribing in their possession, and evaluating to see if they've gotten medications from other prescribers. Many times they'll see us and then they'll have a surgery visit, they'll see the surgeon and forget to mention that the pain medications are prescribed by us, and now he's prescribing medication for them for the same reason, which is a problem. So we have a lot of things that we have to do as far as monitoring to make sure that patients are doing what they're supposed to. And again, we examine patients. Are they coming in active, appropriate? Do they look sedated, lethargic, as if they've taken too much medication? We also communicate with other providers that they're involved with, their primary care doctors. Sometimes we have to talk to psychiatrists. So there's a variety of different things that we do to look at.
A lot of things.
Yeah, it is.
It's a lot of
It is.
monitoring.
And we ask for
that's-
patients
yeah.
from the patients, just because we, these are state mandated things. It's not that we're coming from a presumption of guilt
No.
or misuse, but we are obligated to verify these things to make sure everyone is using these medications safely.
And I think that most people understand that when this crisis got going, a lot of times it was people who had been prescribed a medication by their doctor
Yep.
that either they, and maybe even at times their doctor, weren't quite aware of the risks that was going on.
Certainly weren't monitoring the way we do
And
today.
that's a big change from
Big
what it
change.
used to be.
Yes.
And that could also go for a younger person whose parents may be concerned about having their child have to take a medication like that
Yeah.
as well. So yeah, that is a major change that's happened just here in the past several years, right? That's different. What other ideas do you guys have for people coming in who have, if somebody's watching this and they don't want to make a comment because they feel like something's going on, but they're kind of embarrassed by it, like what are some of your thoughts for a patient that might need some help that hasn't come forward to get it?
As far as pain is
Yeah.
concerned, not to be embarrassed to ask for help. Going in to see, starting off with primary care doctor if they have a rapport with someone, or just coming in to see, a pain management specialist and talk about, how this is affecting their quality of life. There's no reason to be embarrassed about anything. We are medical providers, we're professionals, and we're here to help you to improve your quality of life, not judge you.
Yeah.
Your thoughts on that as well?
No, I agree. I try to reassure patients that pain in and of itself is not a dangerous thing. You can live with pain. but it is pretty miserable. And if we can make your life better by trying to get your pain under better control, I think that should be a reasonable goal.
Yeah, and that's something that if they come in and talk about it, there's new ways that they might not even have thought of that they can come in and address these issues.
Yeah.
Yeah. Okay, well, we're going to keep this Facebook Live discussion up on the WMAR2 News Facebook page, so you can go back and check. You can also make more comments on it if you'd like, and we'll respond to those and get back to you with those questions as well. But thanks so much for everybody who's tuned in to the special Facebook Live discussion here on WMAR2 News. Thanks to Dr. Justin Slavin, a neurosurgeon from GBMC. Thanks so much for coming.
Thank you.
And Dr. Inai Mikandawiri,
Yes.
who is a physician at Cure Smart Pain Management at GBMC. Thanks so much, really. A lot of important information for both of you coming in. Thanks a lot. Thanks for watching. Have a great day.
Thank you.
Thank you.